Hi. Today, Dr. Smith and I would like to talk to you a little bit about EKG interpretation. Recently, we've noticed that when interpreting EKGs, some folks tend to skip right to the ST segment and focus in really on ST elevation or ST depression, looking for a STEMI or an NSTEMI. But there's a lot more that goes into interpreting an EKG. In fact, in the hospital, when I interpret an EKG, in order for it to be a complete interpretation, I actually need to comment on about 4 different categories of information off of that EKG. Also, when interpreting an EKG, like many diagnostic studies, it's important to have a routine that you go through so your interpretation assesses the same things in the same order each time. An example of this is when reading a chest x-ray. If I look straight to the lungs, I might miss other things. So they taught us, be sure to look at the vessels, the bones, the heart, the aorta, all that stuff before you actually look at the lung fields themselves. So similarly for an EKG, there's some things you really need to look at before you get to the ST segments. And so we'd like to take a little while and just go through the generalized approach that you can use to do this, and then we'll get into some of the specifics about things to look for. The generalized approach that most people use for an EKG begins with a rate. Now, I think we're all probably pretty good at assessing the rate of an EKG, and whether you use the big box method or whichever method you like to use, I think we're pretty good at that. So we're not going to spend a lot of time on that. The next thing you should look at is rhythm. And again, I think we're pretty good at rhythm interpretation, whether that's looking for things like AFib, whether that's looking for a normal sinus rhythm versus a not normal rhythm, a tachycardia versus a bradycardia, and all those different things. I think we're all pretty well versed on rhythm interpretation, so we're also going to leave that one for now. But the next thing that you're supposed to look for is intervals. And this is one I think that maybe doesn't get taught or emphasized enough often to EMTs and paramedics. But this is really important, and there's a lot of things we should look at here. You're all familiar with one interval, and that's the PR interval that we look at to assess for a first degree or a second degree or a third degree AV block. But there are some other really important intervals like the QRS duration and like a QT interval, which is actually one of the really important ones clinically at the patient side. And we're going to go through those intervals and how to look at them and what they mean. So we go rate, rhythm, intervals, and the next one we do is axis. Now, axis is one that I think also is not emphasized very well in primary EKG education, but axis can be really important. Axis refers to the general flow of electricity through the heart, and if your heart is really big and shifts over, the axis will change. And if you have certain types of conduction issues, the axis may change. So there's a lot that goes into axis, and we're going to go through the axis and go through a few things that you might be able to tell about your patient based on the axis. And then finally, once you've gone through all of those, then you want to look at the segments and the waves. And so this is the area where we should be looking at our PR segment, our ST segments up or down, or J-point elevation or whatever it might be, and our waves to look for evidence of ischemia or other issues that we want to look at. But this is a general approach that is really a good way to make sure that you don't miss anything as you're interpreting an EKG. And if you get in the habit of always doing this, it will certainly help you to have a more complete picture of what that EKG is telling you about your patient. The next thing I want to talk to you about is the basic concept of what an electrocardiograph or an electrocardiogram is. And I want to remember that just like a lot of the things we look on our monitors, this is actually a graphical representation of data. So we have a plethysmograph, right, or plethysmography for pulse ox. We have capnography or capnograph for CO2, but we also have an electrocardiograph. And whenever we're looking at those, we should always start by thinking, what are we measuring and what's on the axes? So most of the time, the things we look at have time on the x-axis, and then we have whatever else we're measuring here. In the case of an EKG, it's a millivolt on this axis. Now we can have, in a normal EKG tracing, both positive and negative deflections of that voltage. But even backing up just a little bit further, voltage itself, what is that? What does that mean? Well, voltage you can think of as a pressure pushing electrons through, or you can think of it as a potential energy if you really want to get down to it. But it's, again, important to really understand where this is coming from. And in order to see how we get to a shape like this, we actually even have to back up one step further to the cardiac action potential and the ion channels in the cardiac cells.
Hey guys, Dr. Smith here. Going to be talking about the action potential of the heart. So the reason this is important is because this is how we go from the electrolytes that give us voltages to what's going on at the cell level and how that's connected to the EKG, and ultimately how that affects the heart contraction and thus can cause disease processes. So it's going to seem kind of roundabout, but hopefully at the very end I can kind of tie it all together because there's a lot of technical stuff. I'm not going to try and get too deep, but I wanted to give you a little bit deeper dive. So if we start off, we're looking at a heart cell, one single cell. So that's it right there. And specifically, we're actually looking at the membrane. So we're getting even smaller. This is just right here on the cell surface. So if you look at the cell, there's a lot of electrolytes inside and outside. So these are mainly 4 electrolytes that are most important. These are all things we've learned about. So you have your positive electrolytes, that is sodium, potassium, and calcium. And you have your negative electrolytes, and that's primarily chlorine. So when you're looking at this, all of these are floating around inside and outside the cell at different concentrations. So by adding these pluses and minuses together, we can get an overall voltage. So if we're looking at a graph of what's going on in terms of voltage, this is what it's going to look like. So again, we have a graph. We have your millivolts, and we have time. So when we're starting off, this is what the action potential usually looks like. Now, this is actually going to be your 0. So this is neutral. When your heart is resting, not actively pumping, there is no flow of electrolytes. It's just sitting there. And this is in between beats. So if your heart's beating 60 times per minute, this is when it's in that little in between time. So when your heart's resting, it's actually around negative 96 millivolts. And that's where it likes to stay. Now, whoever named these phases decided to start at 0. So there's 5 phases, but there's 0 through 4. So you have phase 0, 1, 2, 3, and 4. And then when you go back to normal or back to resting, you're back at phase 0. So this whole thing encompasses one beat of the heart muscle cell. Again, just to reiterate, this is not the sinus node or the AV node. This is the actual muscle that's going to give you heart pumping. So at phase 0, when we're looking at an EKG, what does this actually correlate to? So this is your neutral phase. So if over here we have a P, QRS, T, there's one beat. Now we're going to start getting into this beat. So this is your interval right here where the heart is resting. Now, right before all this starts, we have our P wave because that's the sinus node kicking off. Again, this isn't the sinus node, so the P wave is not represented on this graph. So once the sinus node initiates a contraction and it goes down to the muscles, you get all of these are controlled by electrically gated channels. What that means is it's waiting for an electrical signal from the sinus node or the AV node to open the channels to let these flow inside or outside. So if they're already outside, they're going to move in. If they're already inside the muscle cell, they're going to move out. So once that signal is reached, all of a sudden, these ions start moving back and forth. And that changes your voltage. So you go from a net negative voltage, so a lot of negative ions versus a lot of positive ions inside, and all of a sudden you start getting positive, positive, positive. And once you reach a threshold potential, this process goes on its own. There's nothing you can do to stop it. So this has a rapid voltage rise. It's not perfectly straight because nothing happens instantaneously, but it's nearly vertical. And this right here corresponds to your QRS. Now, so the QRS is gone, the muscle has fired and contracted. Well, why is it staying positive? So these ions, they don't move by themselves. There's actually channels that help to guide them, and some of them are fast, some of them are slow. Because the fast and slow kind of balance out with the positives and negatives, it all adds up to where there's no change in voltage. It's just sitting right here at about positive 50. And that's where it's going to stay for a few milliseconds, and this is what lets the heart reset. It lets it go back to its resting state and let the heart finish pumping, because if this happened at the speed that it could, your heart would be going 600-700 times a minute. So this is what lets your heart keep kind of a slower, steadier pace. But over time, the net movement of ions sends it back to negative, and your heart resets. So again, this is your QT interval represented right here, because the heart's just resting. There's no electrical activity, so you're at 0 on your EKG. And then when your heart starts to reset back to its resting state, that's when you get your T wave, because again, you have a change in voltage. Now notice that this is going down, this is going up. This is just how many volts is at one cell. And remember, your positive and negative on EKG is which direction it's moving. It doesn't mean positive or negative ions, it means the direction of flow. So we're going from positive on the membrane to negative, and that's represented by your T wave. And back to phase 0, and then we have another P, QRS, T. Now, why is this important? So once you get up here and you're at your positive, this actually starts a cascade of events inside the cell that let the cell pump. So there's all these events going on that allow strands of 2 different proteins called actin and myosin to overlap. And when they overlap, they hook together and kind of almost ratchet. And when it ratchets, it pulls the muscle shorter, and thus you get a contraction. So these electrolytes directly affect the voltage, which directly affects the heart muscle squeezing. So this is why it's so important, because how many times do we see somebody with too high or too low potassium, or somebody that may have overdosed on a calcium channel blocker, or somebody that we're giving sodium bicarb to actually change the voltage of the heart cell. So knowing what electrolytes are involved and how it relates to voltage and your EKG can help you get a little bit deeper understanding of what's actually going on in some of these disease states. All right, guys, let's talk about the axis. So what is the axis of the heart? It's really where is the bulk of the electricity moving. So normal means that the electricity is moving in its normal direction. So, on your own heart, that would be kind of down and to the left. When we're talking about an axis deviation, it could mean the voltage is moving a different direction, or the heart is physically moved, and thus the voltage is moving differently because the heart may be moved out of the way. So, masses in the lung, enlargement of the heart due to high blood pressure, things like that. So by looking at the axis, it can kind of give us an idea of what possible pathophysiology or what possible badness is going on in the heart. So looking at the EKG, I went ahead and drew it out, but here's some of the EKG leads. So we have 1, 2, 3, AVL, AVR, and AVF. Now we don't need all these to look at the axis. Really, the ones you mainly need are AVF and 1. There's many methods to look at axis. I like the 2-quadrant method. It's a more simple one. So when we're looking at axis, how do we actually determine that? So in 1, let's just draw up a couple QRS complexes and EKG beats. So we'll say this one's 1, and this one will be AVF. So to determine axis with this method, you're looking at the QRS complex. You want to see where is the bulk of your QRS complex moving. So in this one, I'm going to draw a little bit more pronounced. You can see the upright portion is much, much more prominent than the lower portion. And in this one, it'll be the same way. So how does this translate over here? So because it is positive in 1, so in reference to 1 right here, this whole area is going to be positive. So this will be positive, this is negative. So positive in lead 1 is right here. Now, if we're looking at AVF, this is positive as well. So for AVF, everything below this line is going to be positive as well. So the sum of all these shaded in areas equals this axis right here. So that means if this is a heart, and over here you have your SA node, your AV node, and here's the bulk of your muscle, all the electricity is moving this way from the top of the heart down towards the apex, so we have a normal axis. So normal axis, now how do we get to an abnormal axis like right or left, or even an extreme axis? So I'm going to redraw this a little bit smaller. Again, we're dealing with 1 and AVF. Now let's say in this situation, your QRS is mostly down in 1, AVF, and mostly up in AVF. So if it was down in 1, that's going to mean it's negative. So you're looking over here in respect to lead 1. So this is positive for lead 1, negative for lead 1. So, oh, this is more negative, so the negative portion of lead 1. This is positive in AVF. So again, AVF is positive down here because it's a plus 90. So all of this is going to be positive for AVF. So where do the bulk of the electricities overlap? Right here. So that means your electricity overall is moving this way, or it's deviated to the right. So this is right axis deviation. Now again, things that can lead to this, anything pushing the heart to the side, maybe COPD, hyperinflated lungs. If you look at a chest x-ray, they always have these huge barrel chest lungs and the heart's kind of hanging down. It can physically move the heart right, or you can have electrical issues, right bundle branch blocks, things like that can move it to the right. Now going back to the same exact graph, let's look at a left axis. So 1, and remember 0, so this is positive for 1, negative. AVF is positive and negative. So in lead 1, we're going to have so if you're looking at 1, the QRS complex is mainly positive, so it's over here. If you're looking at AVF, the QRS is mainly negative, so it's going to be up here. Here's the bulk of your electricity, so it's shooting this way. Now we have left axis deviation. Things that can cause this, again, we're looking at intrinsic conduction differences in the heart, masses, lung cancers that can move your heart up, literally mass effect where it's pushing the heart up, pneumothorax, hemothorax, anything that can actually physically move the heart will cause a left axis deviation. Even heart enlargement, long-standing high blood pressure leading to the heart muscle just gets big and dilated, that will move things up. Now there is a third one, it's very, very rare, but there's a fourth one, there's a very, very, very rare, but there's extreme axis. And this is where, if you go by the same thing, you're going to be positive in, you'll be positive in 1, negative in AVF, if that makes sense. So here's your negative AVF, and then positive 1, but it's very, very hard to get this, and it's extremely rare, but that really isn't so much surmised by this method. Hey guys, so let's talk a little bit about the QT segment. So I want to connect the QT segment back to the action potential in the heart and kind of go over why it's important. And actually it's very, very important because a lot of the medications we give can cause the QT interval to change, and that can be very dangerous. So if we're looking back at this graph of our action potential, and I do want to make a correction. Earlier I labeled these wrong. This is phase 4, 0, 1, and then back to 4. And remember, our corresponding EKG was, so this right here, this segment, from the start of the QRS complex to the end of the T wave, is your QT interval. Now for men, the QT interval is normal at less than 460 milliseconds. And for women, it is 440 milliseconds. So why is this important? What's going on? So I'm going to draw this graph a little bit bigger. Now let's say, remember, this is not the AV or SA node. This is the actual electrical potential in the heart muscle itself. So as our QT interval gets prolonged, be it from medications, electrolyte disturbances, whatever's causing it, potassium, magnesium, calcium, they can all affect QT interval. What we have is this graph actually starts to get stretched out like that. So you can see this QT interval is much longer. Now, since this is the heart muscle, let's say that we have another signal come in from the AV node trying to get the next beat going. Well, this is prolonged. If that signal hit right here, the heart cannot beat. It is physically impossible because we haven't returned close enough to that resting potential to even have the right ions in the right spots to start another electrical potential. But let's say that signal came in right here. The heart has started to repolarize. Now it's getting a little bit more excitable, and the heart can sometimes respond to a signal. So what happens is you try to have a beat on top of another beat, and that's very, very bad. Just the same way that we used synchronized cardioversion because we want to get it on the beat, it's to prevent this exact phenomenon. So what you end up having is once you start stacking beats on top of each other, you go into VFib or VTAC or even torsades. Now remember, the treatment for torsades is magnesium. That helps to stabilize this process and slow down the transmission. And the reason this is important is because many medications that we give commonly affect this. Specifically Benadryl, Zofran, a lot of antibiotics, they can all affect this QT interval. So that's why it's very, very important to check your QT interval, and it's printed out on the EKG before you start giving certain medications. Now remember, on the top of the EKG, you're going to see several numbers. You're going to see QT and QTC. Now what QT is it's the actual measured interval. It's what's on the paper. But the problem is we define QTC based off a heart rate between 60 to 100. So there's a lot of different algorithms that are used and a lot of different formulas, but really the QTC that's printed out on the EKG will be accurate. And that's how, like, let's say somebody has a heart rate of 120, well, the QTC is going to correct for that heart rate to give you the accurate number. All right, guys, now let's talk a little bit about the ST segments. So obviously the one we look for is the ST elevation, the heart attack, the big one. However, there are some other subtle changes that in my mind are actually extremely important because it means we have something we can intervene on before we get to the major heart attack. So here's what I'm talking about. So as we're going through, we have our normal EKG, and like let's say that you end up having your tombstone, obviously massive heart attack. However, there's another very subtle one that I want you to be aware of called the ST depression. So what you have is you have your EKG, and it ends up going back like that. So we have a depression from the baseline. So ST elevation, a STEMI, ST depression, MI. Now what exactly is going on right here? So let's say that we have your heart muscle. I'm just going to draw the ventricle. Now the heart receives blood flow from the coronary arteries that run on the outside of the heart, and you have what are called penetrating vessels. Now what these do is they actually go from outside in to supply blood. So obviously out here at the very edge of the heart, that gets the most oxygenated blood, and then you get more, and then you get less and less oxygen as you go inward. So the very last bit to receive oxygen is this endocardium right here. Now let's say that you have a young person, normal heart, no coronary blockage. This is no problem at all. Plenty of oxygen is getting through to supply the endocardium. As we get older, our diet, we start to have some blockages in here. Well, now there's less blood flow. So the outside of the heart is still getting all it needs, but now the inside is getting starved. So this is when we have ischemia just on the inside, what we call subendocardial ischemia. Now with a full-blown heart attack, you're taking out all this muscle, the electricity is way off, that's where you get the big ST elevations. So the secret to this is when you see these ST depressions, you should be concerned that a partial blockage is causing the changes on the EKG because this endocardium is being affected. So ST depressions, subendocardial ischemia. Now the reason this is very important is because if you've had a major heart attack up here and the whole heart muscle is dead, there's not a lot we can do about that. However, if you're having these ST changes and it's just a partial blockage, this is the time where we really want to intervene. This is the time where we can do a heart cath to reopen this and salvage all of this big heart muscle right here. So when you got somebody with chest pain with a ST depression, I would argue that you probably need to be a little bit more concerned than anything else. However, obviously a STEMI, very, very dangerous. Want to get those taken care of as well.
So thanks for watching. I hope this was a helpful review of how to interpret EKGs. And I hope that going back to the basics and understanding where the EKG comes from, how we get to those squiggly lines, and what might be important on that EKG, as well as having an organized approach to interpreting the EKG, can be really helpful to you. And again, we laid out one approach that a lot of us use, but as long as you cover those things and you have a standardized approach that you use to review the EKG, I think you'll do a lot better. One last thing that I do sometimes see, and I hope that through doing this type of a video that we can get away from, is when I see people print out an EKG off their monitor and then go ahead and just tear off the intervals and all that data that's there. And I think hopefully through talking through this, you understand why that stuff can actually be very important to you. And I am certainly not saying that you want to look at that stuff before you interpret your EKG, but as part of the full EKG interpretation, that is part of what we're looking for. And hopefully we illustrated some of those ways why that's important to you taking care of your patient.